I am honored and super excited this morning to present our invited speaker, Dr. Lisa Hollier. She is somebody that I met many years ago, and it's an incredible, incredible person to have today here. She's a professor at Baylor, had her MD and MPH. We probably originated everything, every great thing back in Tulane many, many years ago, and then has been in Texas, basically at Baylor or UT for the rest of her career. She has been the past president for ACOG, and many of you may recognize her on that role. But really, most of her really close to her heart job has been for maternal mortality prevention. And as that, she's the chair for the maternal mortality reviewed in Texas. So without further ado, I will let Dr. Hollier take the floor.
Thank you so much, Igor. I am so excited to be here. I'm going to see if I can get this share screen done correctly here. We've practiced this. I do hope that it works as expected.
Working.
There we go. Awesome. Well, the first thing I want to do is really just say thank you. Thank you so much for inviting me to speak today. This is a topic about which I'm passionate. My husband and I both would have been happy to be there in person. We are big Wisconsin fans. So someday maybe we'll have the opportunity to do this again. I want to send a very special shout out this morning to Dr. Katie Anthony. I saw Katie earlier on the screen. Also to Bridget Kelly and Michael Beninati. They had to put up with me for a while. And I really appreciate the opportunity that I've had to spend some time with them. Dr. Igor, you were wonderful. It was a pleasure to have the opportunity to spend time with you, and I'm so excited. Dr. Rice, thank you so much for all of your mentorship and your friendship through some difficult times for me in leadership, and I truly appreciate you. And finally, I just want to acknowledge Dr. Doug Glauby, another past president of ACOG, for his friendship and mentorship. I am truly grateful to him. And I just saw Kathy Hartkey. Hi, Kathy. It's good to see you. So glad that you could be here this morning. So now that I've done all of that, I will mention I have no disclosures. I have, as was mentioned, been the chair of the Texas Maternal Mortality and Morbidity Review Committee since its inception in 2013. It has been truly meaningful to make a contribution to the health and safety of so many pregnant and postpartum people in Texas. These are the learning objectives that were designed for the lecture this morning. I'll start with some data from national and regional levels, and then I'll shift to Wisconsin for additional data and recommendations. I think, clearly many of you probably saw yesterday the announcement from the National Center for Health Statistics with the new maternal mortality ratio for 2020. And you can see the devastating effects of COVID with the significant increase in the ratio and the significant racial disparity in maternal mortality. So the CDC, in addition to what the National Center for Health Statistics does, the CDC also conducts national pregnancy-related mortality surveillance to better understand the risk factors for and causes of pregnancy-related deaths in the United States. The Pregnancy Mortality Surveillance System, or PMSS, defines pregnancy-related death as the death of a woman while pregnant or within 1 year of the end of pregnancy from causes related to or aggravated by the pregnancy. For PMSS, the medical epidemiologists review and analyze death records, linked birth records, and fetal death records, if those are available, and then additional available data from all 50 states, New York City, and Washington, D.C. PMSS is used to calculate the pregnancy-related mortality ratio, which is an estimate of the number of pregnancy-related deaths for every 100,000 live births. Based on the CDC's PMSS data, the pregnancy-related mortality ratio increased significantly between 1987 and 2014. Over the last several years, the ratio is not improving. And the last one that has been formally calculated and published was in 2017 at 17.3 per 100,000 live births. So let's talk about that disparity that I mentioned. In addition to no improvement in what we see from the National Center for Health Statistics most recently, the significant increase in maternal mortality, there are considerable racial and ethnic disparities. So this is data from 2014 to 2017. And you can see that the pregnancy-related mortality ratio, the deaths, 41.7 per 100,000 live births for non-Hispanic Black women, 28.3 per 100,000 for non-Hispanic American Indian or Alaska Native women. And then a significant drop-off down to 13.8 for non-Hispanic Asian or Pacific Islander, 11.6 for Hispanic and Latina. And I'm sorry, I missed the 13.4 for the non-Hispanic white. So there is significant variability in the risk of death by race and ethnicity. And this variability may be due to a number of different factors. And we'll talk about some of those today, including access to care, quality of care, prevalence of chronic diseases, structural racism, and implicit bias. The CDC can't disclose pregnancy-related mortality ratios by state, but they can report by region. And so we're going to look at that today. It gives us an important opportunity to better understand the disparities that we see. Beyond this data, it tells a story of regional variation and really shows us that place matters. There's a wide range of pregnancy-related mortality ratios in the different HHS regions and a wide range of disparities ratios as well. So using aggregated PMSS data by region, we can really zero in on important opportunities to focus maternal mortality prevention efforts. And I'll pull out some of these slices to use an example of, as an example of interpretation, and we'll talk a little bit about region 5, which is your region. The largest disparity ratio is in region 2. See here, where the pregnancy mortality ratio among Black pregnant and birthing people is 6 times that of white pregnant and birthing people. And for this analysis, for the purpose of this analysis, this includes New Jersey and New York. The disparity ratio is high because it has a very high Black pregnancy-related mortality ratio and a very low white pregnancy-related mortality ratio. In fact, the lowest pregnancy-related mortality ratio of all the regionalized and racialized data is shown here. This is an especially good opportunity for states in this area to break down their leading causes of pregnancy-related death data by race. Such an analysis could really help local maternal health programs prioritize interventions that address the leading causes of death for Black women in order to address these disparities. Region 6, that's my region, has the highest pregnancy-related mortality ratio among Black pregnant and birthing people. Region 6 also has the highest pregnancy-related mortality ratio among white pregnant and birthing people. There was a disparity ratio of 3 here for our region, but again, the highest pregnancy-related mortality ratios for Blacks and for whites as compared to all other regions. The lowest disparity ratios are in area 4, and you can see area 4 here, the southeast. In your region, region 5, if you take a look at region 5 in blue, you can see the Black pregnancy-related mortality ratio of 35.5 and white of 14.4 with a disparity ratio of 2.5. All right, let's take a look at causes of pregnancy-related death. So the leading causes of the leading cause of pregnancy-related death from the PMSS data was other cardiovascular conditions. Now, this includes congenital heart disease, ischemic heart disease, cardiac valvular disease, hypertensive heart disease, congestive heart failure, and hypertensive deaths that are not due to hypertensive disorders of pregnancy, because you'll find those elsewhere. So when combined, cardiovascular conditions were responsible for more than 35% of pregnancy-related deaths. And this includes the other cardiovascular conditions, cardiomyopathy, and cerebrovascular accidents. So that's more than a third of the deaths in this country, a third of the maternal mortality is due to cardiovascular events. Other leading causes of pregnancy-related death include infection or sepsis and other non-cardiovascular medical conditions. Now, while the contributions of hemorrhage, hypertensive disorders of pregnancy, and anesthesia complications have declined, the contributions of cardiovascular disease and other medical conditions have increased over time. So we see decreases in hemorrhage and hypertension deaths and increases in cardiovascular and other medical conditions. Now, there are an increasing number of pregnant women in the United States with chronic health conditions such as hypertension, diabetes, and chronic acquired heart disease. And I know that you're seeing these women in your clinics too. These conditions may put a woman at higher risk of complications during pregnancy or in the year postpartum. Other leading causes of pregnancy-related death include infection or sepsis. You can see here the deaths caused by hypertensive disorders down here at 6.6, and then the incredibly small number of complications that are anesthetic related. All right, moving here. What this does is present the PMS data on causes of pregnancy-related death divided into the mutually exclusive categories, and then divides the data by race. So this gives you an opportunity to see the differential cause-specific mortality by race. And if we take a look at conditions like hypertensive disorders of pregnancy, thromboembolus, cardiomyopathy, those deaths are much more common among non-Hispanic Black women. In contrast, if we look at deaths from infection, for example, deaths from cerebrovascular accidents, deaths from amniotic fluid embolism, those are occur more commonly among white women. This type of stratification really gives us an opportunity to stratify, to identify which interventions we want to put into place. So as a maternal mortality review committee member, when we did this with our data, we were able to prioritize interventions of programs to address the most common causes of pregnancy-related mortality for non-Hispanic Black women. So this is a really nice way to look at your data. All right, so we talked about the national PMSS data and how this gives us a baseline, but what are specific and feasible actions that can actually prevent future deaths? That's what we really need. And that's the promise of maternal mortality review committees, to really dive deeply and to do that with local content. So maternal mortality review committees are uniquely positioned to provide a much deeper understanding of maternal mortality through understanding both the medical and non-medical contributors, and the development, and to then use that data, develop and prioritize recommendations that reduce future deaths. The maternal mortality review committees go beyond what PMSS does, just reviewing the death certificates and linked birth or fetal death certificates conditions, but they also dive deep into medical records, social service records, mental health records, autopsies, and in some cases, informant interviews, and those can be incredibly helpful. So from this in-depth review in the local context, maternal mortality review committees can glean many more insights, have a better understanding of the opportunities for action, and understanding of how things like racism or substance use disorder may contribute to pregnancy-related deaths. Prior to this morning, I was thinking about asking the group, does any one of you serve on the Wisconsin MMRC? And I already know that Kathy does, but do others of you serve on the Wisconsin MMRC?
Yeah, so Cara Hoppe has been invited to be part of that. And
Oh,
also
wonderful.
the head of neonatology does too. So both of them.
Excellent. That is really great. I am so glad to hear that. It's really important to understand some of the key principles behind the committee. When Texas was first, we had an old review committee many years ago in the late 80s. And unfortunately, many of the maternal mortality review records were actually turned over to a law firm. And there was a tremendous loss of trust in the review process when that happened. And it took a lot of work for us to really overcome that. And I think it's just incredibly important to understand that the review committee really is supposed to be an ongoing, anonymous, and confidential process of data collection, analysis, interpretation, and action. And you all know that from the peer review processes that you have from your M&M conferences. It's really important that we focus on understanding what happened and really coming up with structure, with recommendations that can make change without trying to assign blame or responsibility for any specific death. So it's really, I think, really incredibly important to understand that. And I think even now that hospitals, I know in Texas we have some hospitals who are really hesitant to send us records, but it really does give us the opportunity to have a better understanding so that we can create these recommendations for action. And you can see here illustrated the wide variety of people. When we started with PMSS, it was just a couple folks sitting around the table, but now we've really got this big multidisciplinary group that brings so many different perspectives to the table. And I think that's really incredibly important. The way the input that we get on cases is very different from our community representative than it is from a maternal fetal medicine specialist, right? I am very focused on, what was the timing of this? What was that happened? And our community members like, but wait, what is the context of where she lived her life? So I think it's really important for the review committees to really bring all of that together. I do also want to mention that the maternal mortality review process isn't a substitute for existing processes at your hospital. You may have local factors that are really important to review and discuss, and the review committee does not take the place of that. All right, so I want to talk a little bit about Maria. This is our national data collection system. It's officially called the Maternal Mortality Review Information Application, which is why we call it Maria for short. It's a CDC data system that provides a common data language for MMRCs, facilitating their functions and promoting a national approach. Maria really does help us document a wide range of data on the life and the death of a woman to ensure that the review committee can develop strong prevention recommendations. Over time, the CDC has added elements and different components to Maria based on feedback from users that I think have really facilitated enhanced data collection on things like substance use, discrimination, and racism. More than 50 existing MMRCs in the US. Of the 50 existing, 48 use Maria to guide deliberation. As states collect comparable review data with a truly multidisciplinary membership that reflects the communities most impacted, the national data will improve and point the way to eliminate preventable pregnancy-related mortality in the US. We started the first reports that were coming out of the CDC. The first report was from 9 committees. The next report was 14 committees. And I really look forward to the reports that the CDC is going to be able to make in the future when we really do start to have this common rich data from maternal mortality review committees. Fortunately, Congress appropriated funding allowing the CDC's Erase Maternal Mortality or Erase program to directly fund 30 jurisdictions supporting the review programs in 31 states. So even in the absence of one of those specific grants, Erase supports all 50 states in their work to identify, review, and document opportunities to prevent maternal death. I think it's really been interesting during COVID. Largely the work of the CDC's state level MMRC awardees and other state partners has continued in a virtual space. And so we have been able to meet as a committee. All of our committee meetings have been virtual, as I'm sure yours have as well. And then that interface between our review committee and the CDC, we have regular meetings. That's also been able to happen virtually. And this has really given us an opportunity to really strengthen these relationships, despite the fact that we, once again, have not been together. So let's look at data from the 14 maternal mortality review committees that provided this. And you can see, just as we did with the PMSS data, we're analyzing the MMRC data of pregnancy-related causes of death by race. And again, a very important tool. When we look at this data from these 9 review committees, you see cardiomyopathy and cardiovascular and coronary conditions, followed by hypertensive disorders as the leading causes for non-Hispanic Blacks, and for whites, mental health conditions, hemorrhage, and then cardiovascular and coronary conditions as well. So again, very helpful data in program prioritization. The MMRCs can really get some very, very rich data. And this is just an example. And we have some additional examples from your Wisconsin data in just a few minutes. Stressors in these cases of pregnancy-associated overdoses included housing instability, including homelessness. And that's something that we have seen in Texas as well. Violence. This has been something very important in our Texas data. Sometimes violence across a woman's lifespan. Incarceration history is something that we look for. Financial instability, unemployment, and then loss of a child, children, or pregnancy. And that loss of the child really includes things like a stillbirth or a termination or a spontaneous pregnancy loss, but also removal of a child by Child Protective Services. So these were important different stressors involved or factors that were found in pregnancy-associated overdose deaths. And then you can take this information to make recommendations. I'm just going to give you an example of some of the recommendations. So Access Substance Abuse Treatment Facility was 50 miles or so from the patient's residence. So this is a great example of access. And let's take a look at this third one: lack of continuity, lots of different medications. The corresponding recommendation for the lack of continuity was the state should examine the use of targeted case management policies to incentivize clinics to provide social work and case coordination services during and after pregnancy for a full year, including for women with substance use disorder. As you look at this, what other recommendations can you think of if this particular contributing factor, lack of continuity, lots of different medications, was something that was identified in Wisconsin? What kind of things would you think of? I want you to put on your review committee hat and tell me, what kind of recommendations might you make? What would you think about?
I think one of the things that we've learned from multiple data, but we're lucky to have people like Tiffany Green working in our department, and she's done a lot of work understanding why women wouldn't show up to their clinic, right? And it's as simple as not having a car. Yeah. That basically halts the whole process. So I think telehealth has definitely a role in lack of continuity, and connecting to people at home. Cara Hoppy has deployed or has started that telehealth program for hypertension, and the simulation of that has been absolutely great. Women are more than happy to let everyone get into their phone, into their home, without showing their home, but connecting with the health system. And so,
yeah, that is a great example. That's absolutely a great example. Some of the stuff that I thought of was Medicaid expansion or extension. And it's my understanding that that is something that you all do not yet have. But I believe is something that you have been looking to do. The other thing I thought of was the use of the prescription drug monitoring program. In Texas, the way this was done, the decision was made to actually legislate a requirement for physicians to look in the prescription drug monitoring program database to see if patients had multiple prescriptions from multiple providers before prescribing a new opiate. Is that something that you all have considered? I believe you do have a PDMP, but I don't know if you're required to use it.
Yes, we are, if it's more than the 3 days prescription. However, our review, because of lack of funding and staffing, has just started updating or doing more current reviews. And so the PDMP did not come into effect until after many of the cases that we've just finished reviewing. So it hasn't been helpful for that in that respect.
I understand. And believe me, I understand on the staffing issue and the timeliness of the reviews. You know, Texas, our last report was based on 2013 cases. Right. So in 2020, we published a report based on 2013 maternal deaths. And that was so disappointing for me because one of the principles of quality improvement, right, is timely data. And fortunately, you know, with some additional funding, we have been able to pick things up, and we made a decision to skip forward and start reviewing the 2019 cases. So this last year, we've just been doing 2019 cases to really catch us up. So we'll be much more contemporary, because I do believe that's important, right? To have data, as you just said, Kathy, that is timely and relevant. And that way the recommendations that you make are really much more actionable when you're able to do that. So I'm going to shift gears and go straight to what I found published for Wisconsin. And this is data from 2006 to 2010. You have approximately 25 women who die each year, with about half of those deaths being pregnancy related. And I really wish we were much more like Wisconsin. we have about 160 to 180 deaths that we review, and about 40% of ours are pregnancy related. The disparity that you see that we talked about earlier is there for white women, the mortality ratio of 4.5 versus for non-Hispanic Black women at 22. In the Wisconsin data, the most common cause of death was cardiovascular related, and 5 of 7 deaths were due to peripartum cardiomyopathy. So that data really is consistent with what we're seeing nationwide. Other causes include sepsis, thromboembolic disease, and hemorrhage. The committee found that chronic medical problems were also commonly associated with the deaths, and about 20% of the deaths were found to have at least some chance of preventability. I think, that's an area that I think is going to be really interesting as we start looking nationwide. In Texas, we most recently reported that 89% of the pregnancy-related deaths had some chance of preventability. So there's a lot of difference, and I think it's going to be really interesting to understand where we go with sort of standardizing some of that discussion a little bit more. As you look at this data, do you all think that the causes of death remain similar today in Wisconsin?
No, they're changing. It's definitely cardiovascular is one of the top, but our numbers, our last year's numbers are up to 48 deaths that we'll be reviewing.
Oh my gosh.
And a third of the deaths that we've reviewed in the last couple of meetings are overdose related.
Oh my goodness.
We have a huge problem with substance use. Because thank you, Lisa, for your work as president of ACOG and the advocacy that ACOG does. We passed the Preventing Maternal Deaths Act a few years ago, and Wisconsin got a $1.8 million grant over 5 years. So we were able to hire a dedicated coordinator for the MMRT, a dedicated epidemiologist, a records gatherer, and nurse abstractors. We part of the bottleneck was that we didn't have nurse abstractors to actually go through the sometimes 1,000 pages of records that we get, and we were having some difficulty even getting records, even though it's required from institutions. So because of that, we have now, and when I became the chair about 3 years ago, we have now increased our meetings to 6 times a year. And we are scheduled for the March meeting to do another 10 reviews. We've learned from the Maria training from CDC how to streamline, and we've got great staff that have great ideas. And we are now pre-reviewing every case. Every member of the committee has to pre-review and fill in the Maria form with what their impression is. And everybody has a different perspective on our team, and we're working now. We have an open, we had an open application for the first time to fill about 12 positions to bring us up to the full 30. And we really have worked on and are continuing to work on diversity. And we've got 53 applicants. It's like so exciting that we have such a huge number of all different backgrounds and perspectives. So we are just, this year we started doing 2020 reviews like you to be timely to meet our grant requirements. We typically have done that 5-year interval. So 2011 to 2015, when I came on the committee, we weren't even done with 2015. Now we've completed 2017. So we have 18 and 19 that we're going to work simultaneously with 2020. And by September, I think we'll finish the 2020s. So we're catching up. It's the good news. And this is what the women of Wisconsin deserve. and what are our systems. And I want you to talk too a little bit about the different system levels, or the different levels of intervention that we look at.
Okay, sure. Happy to do that. I don't have specific slides for that, but we can certainly talk about that. So in doing the, Kathy, how about if I come back around to that at the end?
That's great.
As Dr. Harkey mentioned, one of the most recent publications from the review committee was dealing with pregnancy-associated overdose deaths, and the critical factors identified by the MMRT related to overarching themes of access to care, bias and discrimination, policy, and support. The recommendations really do address the critical factors targeting all levels. The report highlights a select few of the team's recommendations that were identified using a modified rapid qualitative analysis, or RQA process. These are just two of the recommendations for the critical factor support. Educational support providers should educate patients about the increased risk of overdose postpartum and when changing treatment at the time of discharge or a change in therapy. And health systems should provide wraparound care coordination for patients and improve and provide options to resume care after leaving against medical advice. And I think this is really important when we think about these opportunities, and the way these recommendations are structured really does give us clear actions, right? So what am I going to do different in clinic tomorrow? Well, I need to be sure and educate my patients about the increased risk of overdose postpartum. We see that a lot in our Texas patients as well. And these recommendations are great because they are so specific. A second critical factor that was identified in the Wisconsin data was access. And these are two of the recommendations from the access category. And the recommendation is that providers, pharmacists, public health, and community agencies should educate the community on the use and availability of Narcan. And health systems should fund and develop programs specializing in perinatal patients with substance use and mental health disorders. So really, really great specific recommendations that are coming out of the incredibly rich data that's been collected by the Maternal Mortality Review Committee. So now we've got to put everything together. By reviewing the maternal deaths, we develop an understanding of the causes and the contributing factors, and then can make recommendations to prevent future deaths. In many states, the Perinatal Quality Collaborative leads the implementation of initiatives. And I understand that the PQC, or Wisconsin PQC, is implementing or has implemented the severe hypertension bundle. That data collection that is performed through AIM will be really important to understand the effectiveness and identify potential opportunities for additional improvement. I think it's also really important to understand contributing factors are in the community domain, and that's going to involve engagement of a broad array of stakeholders to be able to address maternal health in a much broader context. So when we are looking at contributing factors, we look at factors at the patient and family level, at the provider level, at the facility level, at systems level, and then at the community level. So 5 levels in a socio-ecological model that really help us to understand where we want to target our interventions. And I think that's a really important distinction to understand. When we first published our first report and we were talking about patient contributing factors, there was this outrage that we were blaming patients, like it was the patient's fault, and that it wasn't that at all. It was where the interventions, those contributing factors identify where the interventions are targeted. So yes, patient education about the critical urgent maternal warning signs after a delivery. Yes, that is about patient knowledge. but it's not accusing the patient, but rather identifying where we need to target our interventions. I did want to mention cardiovascular conditions, and I know that the causes are shifting in Wisconsin, but cardiovascular disease really is a particular area for me, and I think, you know, at nationwide, this does remain the leading cause of maternal mortality, accounting for anywhere from 25% to about a third of maternal deaths. I had the opportunity when I was ACOG president to pull together a presidential task force. It was chaired by the late Dr. James Martin. And, the bulletin was completed in such a short time frame, only because Jim was such an amazing, amazing leader. The practice bulletin was really aimed at addressing cardiac contributors to maternal mortality, and the guidance that was produced outlined screening, diagnosis, and management for cardiovascular disease in women from pre-pregnancy to postpartum. And, you know, over the last 3 years, there's really been an explosion of interest and research in this area, and really a refinement and further development of the discipline of cardio-obstetrics. This is one of the tables in the practice bulletin. Normal pregnancy and postpartum symptoms and signs can overlap with findings that are reflective of underlying heart disease. It's really important for healthcare providers to become familiar with the signs and symptoms of cardiovascular disease as an important step toward improving maternal outcomes. And this includes emergency physicians at your facilities. They're often the first team members who see women who have symptoms of cardiomyopathy, and misdiagnosis is unfortunately rather common. So, you know, as we think about what are things that you can do differently in your practice tomorrow, you can copy this out of the practice bulletin and distribute it so that people can have a better understanding of, oh my gosh, this woman needs to be evaluated now. I also want to share one of the other, this is a flow sheet algorithm from the practice bulletin, and it was taken from the California Perinatal Quality Collaborative. When they applied this algorithm to their cardiac maternal deaths, they determined that they would have identified more than 80% of the women who ultimately died of cardiovascular causes. So if they had been assessed, if the women who died had been assessed with this tool, they would have been identified, and we could have potentially prevented those maternal deaths. So again, helpful algorithm. You can, you know, you may have one that you're currently using in your work, but this again is another opportunity for something that you can do tomorrow. And I'm so excited. I knew this was coming, it was coming, it was coming. And finally, the Alliance for Innovation in Maternal Health has released the AIM bundle, Cardiac Conditions in Obstetrical Care. And I'm really looking forward to Texas AIM picking this up, and maybe Wisconsin will consider this too, although I totally understand a focus on the AIM bundle for opioid use disorder. I want to point out too that ACOG has revised the original 4 R's that were in the bundle, and they've added the 5th, respectful, equitable, and supportive care. So rather than having a separate disparities bundle, the Council on Patient Safety in Women's Healthcare recognized that it was essential to incorporate considerations for equity in all of the bundles. So I wanted to be sure and share that. The other thing I want to call your attention to is the Hear Her campaign, the CDC's Hear Her campaign. It is a really great opportunity for patients, the community, for providers to learn about important signs and symptoms in the postpartum period and when women really need to present for care. And I think on the provider side, it's incredibly important for us to listen to women, right? So we can educate women all we want. If we're not listening when they're telling us that they're short of breath, we have some work to do. We have some work to do ourselves. And I know that we can do it. And I'm so excited to be here with you all this morning. I want to leave time for some additional questions so we can talk about whatever y'all want to talk about. This does wrap up my presentation this morning. And I will say I'm very excited to hear the residents present as well. So I want to say thank you all so much for allowing me to join you this morning. I'm going to leave you with two of my favorite photos from Lake Michigan from a recent trip to Wisconsin, and I am absolutely happy to take any questions.
Thank you so much, Dr. Hollier. I'm sure I speak for everyone. I say that was a really fantastic lecture. For full disclosure, I took a few pictures of your slides and have already texted them to my family members because I found it so interesting. So I'm trying to pay attention and not respond to the chats that happening around the country from my family, who also found your talk very interesting. There, I'm sure, are going to be a lot of questions today. There's already a few that are kind of popping up in the chat. So anyone who has questions, feel free to put them in the chat, feel free to unmute themselves. I wanted to read a question from Awa, one of our residents. She said she was wondering how the review committee recommendations are communicated if a review of a maternal mortality case reveals some institution or provider specific factors that may have contributed to the poor outcome.
I can certainly speak to what happens in Texas. The review committee is completely separate from, well housed under the Department of State Health Services. The Maternal Mortality Review Committee is completely separate from any of the actions or activities that the Department of State Health Services may take related to hospitals. In fact, in Texas, the medical records are not only abstracted, but they're redacted. So as a member of the committee, I see nothing. I have no idea who the provider was. I have no idea what the facility was. It really focuses us on that general quality improvement aspect from a much broader perspective. The Department of State Health Services, if they were to identify a consistent pattern of issues, they may take additional action, but the review committee itself, we have no specific information. But I think your question about how the findings are disseminated is one that's really been bothering me a lot lately. Actually, I did a lecture for a local medical school. Well, I'll say University of Houston. And, the feedback that I got there when I was talking with them was that, Lisa, the report is like 100, well, I'll show you. This is our report. This is like 100 pages long. And they said, frankly, we're passionate about this, but that's too long. That's too big. Nobody's going to read that. And so we've really been thinking, how do we disseminate the recommendations in a much more consumable manner? So if y'all have any ideas about that, Autumn, Lisa, they're more than welcome to share my email address. And just email me, let me know what you think, because I think that dissemination of recommendations is incredibly important.
There are a few comments as well about COVID in the chat box. Someone had said that Wisconsin, that we had identified an increase in deaths from COVID in pregnant or recently pregnant people who were not vaccinated. And I wonder if you had any comments about whether you've started to see any increases. I'm sure there's going to be definitely a delay by a couple of years, and how the committee is going to be looking at that.
Yes, so I'll start from a national perspective first. So the CDC has actually convened a work group to come together and talk about ways that we can develop additional consistency in the way we look at COVID deaths. And importantly, how COVID could be a contributing factor, even if the patient themselves didn't have COVID. So I think we're really trying, the CDC is really trying to come up with some strategies that can be used by maternal mortality review committees across the country to really understand this in a totally, well, I'm just going to plug myself. I published a paper with Charlene Collier, the chair of the review committee in Mississippi, and Tori Metz, chair of the review committee in Utah, talking about how to identify these COVID deaths and pregnancy and what factors to consider during the maternal mortality review, because we have to think about things too, like delays. Women who delayed coming to the hospital, right, and then suffered mortality from hypertensive disorders of pregnancy, for example, or maybe somebody was at the hospital, let's just say we're in the emergency room for 14 hours before they got transferred to labor and delivery, or women who had complications, had planned a hospital birth, and maybe weren't able to have that birth in the hospital because of fear of catching COVID in the hospital setting. I mean, we saw a significant increase in our home births as well, and I do not in any way mean to imply any issue with that. There's just a lot of different ways that we need to look at how the pandemic itself impacted the care that was being delivered.
Dr. Gaston looks like is raising his hand. Luther, if you want to unmute yourself and ask your question.
Sure, just real quickly. And sorry, I'm post-call, so I'm just a little tired. But I think we need to look at a different model of care. One of the things I think that we don't have in a lot of places nationally is a postpartum cardiovascular type of risk factor clinic. Number two, one of the things I'm thinking about with my partner, a nocturnist, is also a critical care specialist, is creating a different type of hospitalist fellowship, which 1 year is probably dedicated to MFM stuff and labor and delivery and urology and general surgery, but another year to critical care, because I think we're seeing sicker patients. And I think that it's very important to have the hospitalist and or labor doctor versed, even if that patient goes in the ICU, to how to handle these patients that are critically ill. So I don't know what your opinion on that is, but I really do think we're seeing sicker patients. I'm not sure if it's the obesity, the drugs, or whatever the case is, but this is not the same group of patients I saw when I started residency in 1991.
I think there are a number of different factors. I do agree, chronic conditions are definitely rising, right? So when we look at Texas numbers for hypertension, for cardiovascular disease, for diabetes, for obesity, all of those things are increasing. We're also seeing women with older age at the first pregnancy. So there are a lot of factors that are really contributing to having sicker moms that we're taking care of. So, opportunities that we have to improve the skills of clinicians are incredibly important. We identified gaps in clinical knowledge and quality of care. We identified delays in diagnosis and delays in implementation of appropriate treatment in a significant number of maternal deaths. And so when you can put providers who have a higher skill level, I think that's incredibly important. Another part of this that's really important is thinking about levels of maternal care. And I don't actually know. I looked up a bunch of stuff about Wisconsin, but I didn't look that up. But levels of maternal care is definitely something to think about, making sure that women get care in a facility that is appropriately meets her individual needs. So your recommendations, I think, though, are great. Cardio-obstetrics clinics would be great. Additional training for your hospitalists would be great. Anything you can do to enhance the knowledge and clinical skills would be terrific, and I think would prevent maternal mortality.
Thank you.
We have a bunch of questions coming in. We do have a little bit of extra time because we only have 2 residents presenting. So I'm going to let this conversation continue some. We have a couple of comments in the chat that I'll go through first, both kind of related to abortion. So abortion affects maternal mortality. One of the questions is, how is Texas evaluating the effects of the recent restrictions to abortion access on maternal mortality? And then a similar kind of question, wondering how the MMRCs examine abortion access and restrictions as a contributing factor to death.
This is something that as a review committee, we're going to have to be developing. What does that look like? What are the factors that we are going to be using to assess this pregnancy intention? We actually developed a sociospatial dashboard that helps us understand the community. And we're piloting a new tool to help us look at social factors that contributed to maternal mortality. So pregnancy intention is going to be one of the things that we're going to need to look at. But what we try to do is see if other review committees have already come up with sort of a standardized way to approach the identification of these cases. And then if one doesn't exist, we will have to be the group that comes up with that. And I think, unfortunately, with the Texas legislation, we're going to be the state that really needs to come up with a framework for how we identify these cases from the information that we receive as a maternal mortality review committee.
Dr. Beninati, you want to unmute yourself and ask your question?
Thank you. Hi, Dr. Hollier. Very nice to see you. Bridget and I were excited to be able to listen to your talk this morning. When I give talks to NICU providers and anesthesia providers about OB critical care, a common question that I get that I don't know the right answer to is, what's the best model of care for a critically ill pregnant or postpartum patient? Where should they be? Who should be providing the care for them? And I was wondering if your work in this topic has informed your answer.
I have not done enough really specific work, I think, to really be able to say, should it be, X subspecialist or Y subspecialist versus a specialist versus anyone else. My instinct would be that it really, I think the best care happens in a multidisciplinary way at a facility that has appropriate personnel, facilities, policies, and procedures. A facility that is prepared to meet the specific needs of a woman. I'm just thinking, like, from a cardiac perspective, right? Do you need somebody from EP when you're doing a cardiac case? Certainly if she's got arrhythmias, yes, I think someone from EP is going to be really helpful in providing that care for her. But do you need that in other situations? Michael, I wish I had a really good answer for you, but just like, however many years ago that was, I appreciate your question stimulating me to do more work, more research, and learn more.
Well, it makes me feel better that you don't have the slam dunk answer either, because I tell them, similar things, that we did it one way at Baylor and one way Brown and one way here. And I'm not sure that anyone knows the answer, but I think it's worthwhile to keep trying to figure it out.
Kathy?
Yeah, just a couple of things to fill in. On that topic about abortion care, we do make recommendations that on cases where it appears that somebody wanted an abortion and didn't get referred or couldn't get to the services and then had a death. I mean, we make specific recommendations for the state of Wisconsin. We also have seen cases where someone had an inevitable AB, but was not treated, was potentially sent out of the hospital and later died because they couldn't get actually treatment, not for just an elective AB, but a necessary AB. So we're definitely making statements about that. I'm going to be on a panel next week talking about our abortion situation in Wisconsin. And were it not for Governor Evers, we would be just like Texas right now. And there are bills right now in our legislature that will, if it's not for the governor that we currently have, we would be in a world of hurt, just like Texas. We do have a perinatal quality collaborative. I know there was a question about that. Started about 5 years ago. ACOG was a founding member. And as Lisa mentioned, they are doing a number of different AIM bundles. And I'm on the steering committee. And I think we've got several University of Wisconsin people that are participating in different fashions and have given presentations for their regional forums. And the levels of care is a big issue in Wisconsin. We have tried for years to get hospitals to voluntarily do this. Wisconsin Hospital Association is opposed to mandatory disclosure of levels of care, which doesn't make any sense to me, but that's where they're at. And luckily, we have great researchers in your departments, and with Katie Anthony and Jenna Racine and Cynthia Watlett, we published a paper recently on the barriers to disclosing levels of maternal care. It would help tremendously. We do know some of them. And so when we do our reviews, that is included in the reviews, if we know the level of care or if it's not disclosed. So we are looking at it in some fashion. And we also know we're using I think it's the county public data on whether there's increased higher access to obstetrical care, or if there's a greater number of homicides, or there's different statistics that they put together a profile for the region, but we don't know specifically where they're at. So we do have some social determinants of health criteria. So that the levels of care, I think, and we know right now that it would be difficult to get it passed through the legislature, and we would prefer not to do that like Texas did. I know that in Texas you made it a requirement. I'm about ready to say let's just go for that, but that would be a big help.
Yeah, I really look forward to being able to get some data that really supports the use of levels of care and implementation of levels of care, improving outcomes. I mean, you got great data for NICU, right? Had it for a really long time. I'd love to see that for moms as well.